This episode is brought to you by Physician Services USA. Physician Services USA is your trusted partner in streamlining operations for independent physicians and medical practices. Their team of dedicated, South Carolina-based professionals takes the hassle out of billing, credentialing, practice management solutions, and more. If you'd like a well-run practice with all of the efficiency and none of the headache, visit physicianservicesusa.com today and discover the support you deserve. You're listening to the IndeDocs podcast, where we discuss important issues related to our mission to preserve, promote, and protect the practice of independent medicine. Thank you for tuning in.
Welcome to IndeDocs. My name is Dr. Morris Brown. Thank you for joining us for this discussion about rural healthcare, some of its challenges, and how we can start to change things for the better, because 1/3 of South Carolina is considered rural. Also, I would like to give a disclaimer that the participants in this podcast are not representing any organization, but we're representing our personal opinions and experiences. A little bit background on myself. I'm a rural physician. I'm a family medicine physician who specializes in family medicine. I've had the honor and privilege of serving for the past 30 years, serving the patients in Lake City and in Kingstree. It's the best professional decision I ever made. I've had the privilege of providing health care for families for at least 4 generations deep. They have accepted my family and me within this community, and it's been embracing and just refreshing, and I have no regrets of practicing rural medicine. A lot of colleagues feel that it's impossible, it's too stressful, it's too difficult, but I'm here to tell you it is not. I often tell my colleagues, I am not that smart, but if you can learn a Krebs cycle in medical school and residency, you can sit down and learn a CPT code and how to handle a medical business. It is not that difficult. I think most importantly, I have the opportunity to advocate for the patient unfiltered. I do not work for any healthcare system or any insurance company. I purely work for the patient only. And that has been very rewarding for me. I would like to introduce our guest, who is a healthcare professional. Her name is Mrs. Regina Nesmith-Dimery. I consider her a colleague and a friend. She's a great asset to this community. She was born and raised in Williamsburg County, and she fortunately came home to serve her community and does an outstanding job. So I have the utmost respect for her, and it's been a pleasure working for her, but I'll let her tell her story. So, Ms. Regina, may you tell us a little bit about your experiences and yourself and your background?
Dr. Brown, it's so wonderful to be a part of this conversation. My background has been about 30 plus years in public health services, doing a lot of coalition building and work in the communities that focuses on some of our chronic disease issues, other health issues in the community. So it's been a challenge to work in rural areas. And as you stated, we have to partner. We have to do the work together in order for us to be able to, project the needs or focus on the needs and issues of the community.
And you do a great job of what you do, and I appreciate you. So today's discussion, we're going to talk about 3 topics and dive a little deeper later. First topic will be low number of rural physicians. The second topic will be uninsured patients in rural areas. And the third topic will be lack of access in rural areas. So let's start with the first topic, the low number of rural physicians. The Association of American Medical Colleges state that there's a shortage of 100,000 physicians in America, and it's more pronounced in rural areas, especially in South Carolina, because it's harder and harder to recruit physicians in rural areas. Usually they're born and raised from a rural area, and they're usually the physicians that we recruit. However, we need more physicians to care for especially our population. There are many barriers to that. Some of it's corporate medicine, we could talk about a little bit later, and some of it has to deal with the compensation of rural physicians. There's a disparity between the specialists and primary care, and that needs to be addressed. And unfortunately, and we talked about this previously in the past, we really don't practice healthcare. A lot of time it's sick care. And some of that is secondary to corporate medicine, where corporate medicine employs physicians and they consider them a FTE, which is, I didn't know what it meant, but it means a full-time equivalent. And I asked the hospital administrator once about that his business model, and basically the way they look at it, they're cutting overhead. They are trying to replace physicians with mid-level or advanced practitioners and cut the price. And the model is they have the primary care referred to the specialist who order more expensive testing, which generates more money for the healthcare system, whether the patient gets sicker or healthier. And unfortunately, the patient usually gets sicker with that model. Our model is to keep people healthy, provide health maintenance, and worry and be concerned about their entire well-being. Other issue is pay, which you talked about. Primary care, unfortunately, this time not paid fairly, but that's, in my opinion, is going to be addressed by insurers and Medicare hopefully soon. But that's a little of my opinion. Ms. Regina, what are your opinion about increasing the number of rural physicians?
Well, Dr. Brown, I've had the opportunity, and when you said earlier about me being born and raised in Williamsburg County, I was born in Philadelphia and spent a good part of my life in Philadelphia. So I've been able to witness both sides. I've been able to witness urban as well as very rural sides of healthcare. And it is very important that people understand that when you have access to providers like yourself, that you've dedicated your life and your career to doing healthcare in rural communities, that is so important for rural residents to be able to connect with their physician. Basically, what I've seen is that once that person connects with their physician, they really have not only, they trust their doctor, but they have some faith in their doctor to be that confidant and also to provide them with the care that they need to sustain. And you've seen generations of people in your practice. And I know that in my family, there has been generations that have come through your care and has benefited my family as well as myself. So having the rural physicians, we need more doctors in rural communities. There's not an opportunity oftentimes for that glamorous job that people are looking for when they get out of school, because rural communities sometimes don't offer the types of resources that they're looking for. But we do need to have rural doctors, and they need to be able to work in communities because, again, they are an important factor in our communities, and just as you have been an important factor in our community. People know you, they really respect you, and you've provided care and resources for the community and been a connection to the community.
So let me ask you this. How would you recommend that we go about correcting this issue with a low number of physicians in rural areas? What would you recommend that we do?
Well, I think that we have a lot of social media outlets now that have been pretty effective in making sure that people are getting connected to areas. And I think that oftentimes it's not glamorized. Rural communities are not glamorized. They're just, rural, and you don't have the popularity and the resources in rural communities. But I think that if we market about rural communities and making those personal connections to people and families and taking care of generations of people and looking at rural aspects as a wonderful thing, that, you're living in a great environment. Your environment could be a possibility to draw you in. You're having fresh fruits and vegetables around you if you're in a very rural area, because we do a lot of gardening, making sure that people who like to hunt and fish, we have those aspects in rural areas. So we do have things to attract young people to come back to rural areas and provide those types of services and resources. So I think that the way it's marketed in, physicians coming out of school and being able to provide some incentives also to those that are coming out of school would be important as well.
I agree. It's good valid points. Yeah. Also, I think another thing I just thought about is increasing the rural residencies for family physicians, where instead of doing residencies in a urban setting, that they actually embed it in the community that they might potentially serve and work with older, more mature physicians in the community. And I think they really don't have an appreciation until they actually live and breathe it and stay there.
Correct.
once they see how the community and people like you and all the stakeholders come together for the common good of the community, I think that'll make a great impression on younger physicians and even physicians that worked in the urban area, never been in a rural setting. Once they stay there for a while and see the actual community, how it works, I think they'll be thoroughly impressed. But one thing I found about rural people is that they are very resourceful. They might have limited resources, but they're very, very resourceful, and it's impressive. And I think that's another way to increase the number of rural physicians. But you made all valid, great points. Going to the second issue is uninsured patients. As we well know, in rural areas, there's a high population of uninsured patients. And South Carolina is one of the 10 states that did not expand Medicaid. And I know that's a hot topic, various views on that. But the fact of the matter is, basically, for every $1 that the state puts up, the federal government matches with $3. And that's a pretty good business deal. Also, the KFF media reports that if South Carolina expands Medicaid, an additional 188,000 uninsured non-elderly adults will have coverage for their health care. They currently don't. Also, more importantly, in a report conducted by the White House, it stated that Medicaid expansion in South Carolina would save 200 lives a year, which is impressive. And I've talked to some colleagues, some legislators and decision makers, and some have different views, and I respect that. However, they don't offer an alternative. So we continue to do the same thing we do, and we have poor outcomes. So I think if someone can't come up with a better idea, we need to expand Medicare. I know there's some state organizations, medical organizations are now being a little more aggressive, especially with mental health, because that's the bipartisan issue. And South Carolina expansion of Medicaid will help that issue and address it, in my opinion. I think there has to be some communication between the policymakers, the citizens, and the healthcare workers to resolve this issue. What is your input? What do you think we need to do?
Well, again, more education. I think that if we try to educate our community on some of the issues that we're facing, especially with things like Medicaid expansion, that they may be able to work with their legislators and tell them the needs and issues that they're facing in areas, because economics plays a big factor in rural communities. The job market may not be as such where people can get the types of health coverage that they really need to do their well care. So we really need to be more advocate and vocal on this type of issue, because the resources are definitely needed in our communities. But unless we educate and talk and communicate with our community members, then they really won't understand or think it's that big of an issue.
And on the flip side of that, now that we both work intimately with our community, what I've found from patients and the citizens in the community is that there's some sense of apathy. And the legislators work for us. And I try to relay that to the patients, but I don't think they really understand the power that they hold and the influence they have with the decision makers. So how do we go about addressing that?
Well, I've often seen that there has been a disconnect, just like you're saying, with our if they're servants of our community, if our legislators are servants of our communities, then they need to know again about what the issues are among the local residents. And that disconnect has to be fused together again with communication. Oftentimes, working with legislators and local governments, they are not knowledgeable about a lot of the needs and issues in local communities. So if I don't know that there's an issue with diabetes in our community, then I'm not going to be a big advocate, for healthcare in the community. But I think once we start educating our legislative delegations, our county governments, even our communities at large, our community stakeholders, very unknowledgeable about a whole lot of things that are going on in our community, and they have no idea or no clue about some of our issues that are going on in our communities. We have high rates of maternal and infant mortality. We have high rates of hypertension and diabetes. We have all kinds of chronic diseases that we need to have addressed, but they are very unaware that these are conditions and the problems that people are facing in our communities with limited resources. So education, I'm a big advocate for education, but unless we sit down and start talking and communicating and getting these points across, that we're still going to have that same disconnect and still get the same results.
Absolutely. Going on to the next topic, the third one is lack of resources. As we well know, that's a concern. We often hear about the social determinants of health, and some would call it the political determinants of health. And as we well know, we personally experienced, we just built a brand new hospital in Williamsburg County, and it's beautiful. It's beautiful, well-staffed, but it's in the middle of a cornfield. It's not in Lake City. It's not in King Street. It's the healthcare for our community. And unfortunately, a lot of people do not have transportation, so they cannot make it to this brand new hospital. And that is the issue that we need to address. We well know during COVID, in Williamsburg County, rural areas, the lack of Wi-Fi. When we went to telehealth and went to e-learning, unfortunately, there are still dead spots in Williamsburg County that have no Wi-Fi whatsoever. They use school buses as hot spots, and it still didn't work, unfortunately. So those issues need to be addressed with the FCC and the legislators, and improve Wi-Fi so we can more educate our public and the community and affect the education and the healthcare.
And sometimes, Dr. Brown, that people don't understand that all of this impacts our healthcare. When you talked about the social determinants of health, and for any audience member that doesn't recognize the term, the social determinants of health are the conditions and environments in which people are born, live, learn, work, play, worship, and age. And there's 5 domains of those social determinants of health: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. All of those things impact our healthcare. When people talk about health, they think about disease and preventing disease, but they don't understand that there's so many other factors that deal with health, that impact health, that need to be addressed, not just the body, but there's things around us in our environment, in things like Wi-Fi. I know that it was very impactful for me to get a doctor's visit during COVID from your office, because I was, we couldn't come into the office. So I was able to get an exam through telehealth. And so that saved me quite a bit. However, there's still my residents out there that are without Wi-Fi and broadband. And, we have low internet, or our internet services are poor. So we need to work on addressing things like that. And especially our elderly, greatly impacted during that time, because they were challenged with working with technology. They didn't have the technology that was needed to do a lot of the telehealth. So we are working on some of those resources for our seniors in our communities. One of the things that we've done through the Building Resilient and Inclusive Communities grant that we got through our coalition during that time was to actually help provide some tablets for the seniors in the community, and actually having those seniors to sit down and learn how to use their tablet to communicate with their families, because social connectedness became another social determinant of health. So that social connectedness, them not being able to communicate with their family, them not being able to communicate with their physician, all of that impacted their health and well-being. So it was just so important that things that we just take for granted, that internet access, it's a big deal. It's a real big issue.
Absolutely. What's amazing, though, you just mentioned the tablets and the smartphones. In our office, we have what's called remote patient monitoring, where the patient takes a blood pressure machine and take it home and monitor the blood pressure. And it's an app on the phone, and it sends the data to that chart, and the nurse and I review it on a daily and sometimes weekly basis. But it's amazing how the seniors embrace the technology. It surprised me. I really thought, we had to hold their hand and go slow. Once they were introduced into just the basic, they just took it and flew with it. I mean, that was really surprising to me, and that was encouraging. So I think if they have the tools, they can actually improve the healthcare and take it and run with it.
Right.
I tell you, what's encouraging is at least we're having these conversations, because of the past 30 years of my practice in medicine, we buried our heads and act like they didn't exist. And I knew personally, if a person can't afford the medication, why should I write it? You know, you got to be practical, even though you have the intellectual knowledge and everything. But the reality is people often cannot afford medication. They have to pay the bills. They have to feed their families. They have other priorities. And these social determinants, at least they were recognized, giving it a label and addressing and talking about them. Another encouraging thing throughout the state and the national level is now rural is encouraging. People are talking about it. Everybody's adapting that label. The major universities, the major public health organizations, they are actually embracing rural, which is very encouraging.
Yes, and I've seen that happen, that now more resources and even funding is coming to rural communities. There is a bigger spotlight on rural communities. So hopefully we're able to access more grants and more resources for our rural areas. But the tide is changing in terms of the way people are looking at rural and rural healthcare.
We'll be right back after this.
If you are a physician or an administrative professional working in a medical field in South Carolina, we invite you to consider joining the IndeDocs membership. Members have access to exclusive resources and networking opportunities and are an essential part of supporting our mission to preserve, protect, and promote the practice of independent medicine. For more information, please visit our website at IndeDocs.com. That's IndeDocs.com.
It's truly amazing. So what do you think? What happened? I just go to work every day and see patients. It's amazing now we go to these meetings, we have these podcasts, and we talking about rural. So what happened?
There may have been a big shift in rural, especially during the pandemic. We were very under-resourced during the pandemic. And so that kind of put a national spotlight on things. Even though people lived in major cities and they had a lot of things around them, rural residents really suffered a lot during the pandemic. We didn't have the health resources, didn't have the other types of services that were available in larger metropolitan areas. So it is a challenge for rural residents to bounce back from things like a pandemic and not be able to move forward in terms of to have better health outcomes.
Very good point. I think you're right on point with that. If anything came good out of the COVID epidemic is that it brought attention to the rural and underserved, no doubt about it, because it was embarrassing to go to these meetings and people are astounded. They ask me, how can this happen? And I said, look, this has always been here. It just, when something like this happens, it's exacerbated.
Right.
Now you have to look at it and deal with it.
Mm-hmm.
So anyway, let's shift gears. Let's talk about the positive.
Okay.
Okay.
All right.
Reasons of hope. Okay. What is your recommendation? How can we move the needle? If you had the magic wand, what would you do?
Well, if I had a magic wand, first of all, of course, we talked about this a little bit earlier, doing more expansion of Medicaid, also working with our communities to look for additional resources and create partnerships, because that has substantially worked for us in our rural community of Williamsburg County to create those partnerships to address some of our local health and social issues. For instance, we have been able to work with our community coalitions, and they have actually embraced health, and they're looking at what we call community health improvement plan. And those community health improvement plans actually focus on health and the social determinants of health and how we can collectively come together as a community to address some of these issues. So we have a Dr. Brown, but we also have other agencies and organizations in our communities that need to be working together to address some of our community health issues. So that's a very positive thing that I see. And if I continue to wave my magic wand, I would want to be able to help create more partnerships, look at how our coalition is affecting our community, making sure that we have people like community health workers in our communities helping with some of the social determinants of health, as well as other health organizations and agencies. We talked about mental health. I know that right now, mental health is gearing up to have a mobile unit out in the community, because in a rural area, when 5 o'clock comes, then the services are over and there's no services on the weekends. So those mobile health units would definitely be something that if I wave my magic wand, I would definitely create those types of resources for the community.
Good idea. Good idea. I tell you, what's amazing to me as I travel throughout the state, and I see people like you, they're in the trenches, boots on the ground, and doing great work and addressing the issues in each community that they serve, because each community has its own idiosyncrasies, but rural is rural. But it's amazing. I wonder, what would you recommend? How do we collectively get together to address these issues? When I go to Forest County, they kind of doing their thing. Then Georgetown County is doing their thing. And everybody's doing a great job, but somehow there's a disconnect and nobody's kind of working collectively to improve the healthcare of rural citizens. Because like I said, 1/3 of this state is rural. That's significant. So what do you recommend to address those issues?
Well, we have to look at systems change in our communities. What does the healthcare system look like? How are we communicating with each other? For instance, it was so phenomenal with our coalition when we were able to get a grant for about $50,000 to do the In It Together to End Diabetes, or to prevent diabetes, to prevent diabetes. In that In It Together program, we were able to actually look at our community and those persons who had prediabetes, trying to make sure that they were in a program or service that we would be able to connect with. And what we did was, through our coalition, we looked at those providers in the coalition that were able to work with those individuals that had prediabetes and would be able to be referred to that program. And you were one of those providers that was able to refer people to that program. But we had to sit down at the table. We had to talk. We have to make those systems issues. We have to be able to communicate with each other to know that we can make a difference. But unless we are on the same page working together, then we're not going to be successful at what we're doing. We're just going to be in silos, working by ourselves. But we want to be able to work together, be able to communicate effectively, and be able to get the services to the people that really need the services.
So for anyone that's listening, what would you recommend that will be the first step to get things to improve the healthcare in their community?
One of the things that I would suggest is getting involved with your local community coalition. Most of our community coalitions have a diverse group of people. They could be a resident of the community. They don't have to be a service provider. They can just come out and be a great advocate in the community. But our community coalitions have been designed so that they work with local residents to create local solutions to local problems.
How would you recommend what do we need to do to engage our local legislators?
Well, a conversation. Oftentimes, we don't sit down and have those conversations with our legislative delegations in our local areas. And I think that it would be great for us to sit down and just have a roundtable discussion. It doesn't have to be anything formal. Sometimes just informal talks around a dinner session can be the most convening, but the most meaningful types of ways that we can communicate with our local legislators.
Well said. I just sit back and look at people like you, like I said, in the other communities. Somehow we got to collectively put our resources together to improve the healthcare of South Carolina.
One thing that I do like about your practice, Dr. Brown, and you as a physician and a community advocate, is that you are community focused. You're concerned about the residents in the community, but you also reach out and provide residents with information and other resources. I remember a couple years ago, we worked on a project with your practice called Walk with Ease. And that particular program is an evidence-based program through the Arthritis Foundation. And the Walk with Ease program, we were able to get a local sorority to partner with your practice. And we actually were engaging the women in the sorority to walk. This was a 6-week program, and they walked and they had classes and they changed their lifestyle. We had one person in that 11 weeks to lose 11 pounds. I'm sorry, 6 weeks to lose 11 pounds. And then we also had a significant drop in blood pressure from all the participants. So not only are you within your practice practicing medicine, but you're also making that connection with the community and making sure that people have the resources and other connections to programs within the community. So that's what I really like about you, Dr. Brown.
Well, I appreciate. I do remember that program. That was a great program. I was just so amazed at the participants and you and how you organized that.
But you're one Dr. Brown. So unless we come together as a community, just like you're saying, then we will be able to, do more collectively in our communities. But we are just going to have to empower more people to be community champions and advocates for our health.
Speaking of resources, how do we go about obtaining grants to improve the healthcare in rural communities?
That's a great question, Dr. Brown. And there are various ways that you would be able to get grants in terms of looking at different areas or looking at different organizations that are essential in helping to get grants for the community. I know through our community coalition, we have worked with several of our partnering agencies to look at and identify grant sources. And then we are able to actually focus on those grants and actually do the grant writing within the coalition with a team of people. Oftentimes, we have counties that have actual on-staff grant writers that look at different types of grants. I know there was a couple years ago, the county looked at food insecurity and actually focused on getting some grants to do a farmers market in Williamsburg County. So we can look at our local county government. We also have agencies and organizations that you can reach out to. We have some nonprofits, and we also have some grant writers within those nonprofit organizations that have actually worked on grants to address rural health and rural issues within our community. So we do have grant writers. We do have nonprofit organizations that have been receiving grants. And we also have some of our professional staff in some of our state agencies that may be able to assist with grant writing or at least grant finding.
So are these grant writers employed by the county or state, or what organization employs these grant writers?
Well, we have some nonprofit organizations that have persons that actually write grants for their organization. I know that some of the county or local governments do have a grant writer on staff that they actually pay a full-time salary for that person to be able to look at grants and write grants. And also, there may be a group. I've worked on groups of teams of people, especially within the coalitions, to actually receive grants from different entities. So, for instance, when I addressed the diabetes grant, that diabetes grant was actually given from a state agency, and that information came out through a listserv through the coalition. So we were able to look at the information, and we were able to actually get a 2 to 3 person team to work on the grant. And then we submitted it and we were approved. So oftentimes I look at doing committees or groups of people that can share the burden of grant writing, because sometimes it can be challenging, but certainly it can be done. So not having one person, but having a group of people to actually unpack, unload it, and then put it together, that has been a very helpful thing for some projects that I've worked on. And there are also other resources out there in the community and also on the internet. The internet has a wealth of information in terms of how to develop a grant proposal. You have bookstores that you can reference, but certainly the internet has a wealth of information on how to do or how to develop a grant proposal.
Good points. Can you unpack a bit further some of the types of things we could do in a rural community to start to move the needle forward?
We do have a lot of resources and services and programs that are helpful in moving that needle forward in rural communities. Being able to work with our community stakeholders and being able to work with people in the community to be able to create some programs and to look at prevention as one of those key areas that we need to be more focused in. What are we going to do on the community level to create programs and services that are going to be able to address some of our health issues? So community stakeholders, the faith leaders, the administrators of communities, we're looking at local government, agencies and organizations, state and local agencies. Our grassroots organizations are going to be essential in working together to do a lot of the communication as well as systems change to be able to sit down at the same table and create a space where we all are, thinking on the same page, being able to address some of our local needs and issues in the community and be able to be a better resource for the community, because some of us are providing resources, but how are we providing those resources, and are we adequately providing those resources, or are we working on one accord with the resources that we're providing in our communities? Because we have essentially about a quarter of our population living with diabetes. So how are we providing those types of services in our communities, and are people managing their diabetes? What are we doing on the local community level? What are our parks look like? Are people walking? Is walkability and movability something that we need to address in our communities? What does our healthy food access look like? Do people have access to fruits and vegetables? We only have 3 grocery stores in Williamsburg County, and we are a county of about 930 square miles. So 3 grocery stores in an entire county to serve over 30,000 residents, that's really limited. So where are people going to access their fresh fruits and vegetables? And we were introduced during the pandemic to a new program called Food Share. Food Share is an initiative where food boxes of fresh fruits and vegetables are being able to be distributed in communities for a low cost. And for those persons who receive SNAP benefits, they're able to get the boxes for about $5. And those persons who pay cash usually pay about $20 to have this fresh fruit and vegetable box. And we have a food share hub that was created in Williamsburg County through a local pantry, food pantry. And it has been such a great resource in our community that we are now getting more fruits and vegetables into the homes and at a lower cost than they would be provided in a local grocery store.
Absolutely. I always tell people, probably your most valuable asset is time, because we all have limited time on this earth. However, if you don't have good health, it's an issue. And people really don't pay attention or concern, especially in rural areas, about their health until they're sick. And I always give them the car analogy. We take better care of material things. We rotate the tires in automobiles. We change the oil. We do health maintenance in those things, but we don't do health maintenance on ourselves. And the body is just as sensitive as an automobile or material things. If you don't take care of yourself, your life expectancy is shorter. And that's what we find in rural areas. We have to make healthcare a priority. Can't just wait till we're sick. We got to get out in the communities like you're doing, and you do a great job. I know, well, the audience might not know, but at least a year ago, you worked with my family personally, my daughter and her family strengthening program, and just giving them some background on how to keep your family's health safe and prosperous. And I mean, you do a great job of bringing all those parties together in the community, improving the healthcare of the entire community. So, Miss Regina, any final thoughts?
Well, we need to empower community champions to have a voice for us in our communities as well. And, I consider you as a community champion because, you're a healthcare provider, but you're also a person, a resident that actually lives and plays and works in the community. So people look up to you, but we do need more community champions out there playing more of an advocacy role in our communities. Sometimes, I feel like if I can clone myself and maybe you into, multiple people, then we would have those persons out there. But we have to be able to empower more people in our communities to be able to speak out and to talk about these things and be able to put them in a champion's role, because that's another way to get things started, to make sure that you empower people to be able to carry that torch, to make it meaningful for them to be able to say, I want to do something to be a change agent in my community. So empower me with that information so that I can get it out there and start working in my community to make it a better place to live.
Well said. I would like to thank Ms. Regina for being our guest for this episode. And to the audience, thank you for joining us. Please make sure you like and subscribe, as that really helps us to grow this community and spread the word about the issues we're exploring today. And please tune in next time for another great discussion about independent medicine in South Carolina. From all of us at IndeDocs, take care and stay well.
Thank you for tuning in to this episode of the IndeDocs podcast. Our producer is Jenna Leaf. Promotional support by Uplift Marketing. Mixing and mastering by Noah Martin. Content editing by Jenna Leaf. Additional production support by Noah Martin, Rebecca Lockhart, John Robinson, and the IndeDocs Board of Directors. For more information, please visit us online at IndeDocs.com.